Thank you, sir. After 6 delicious heavy meal lecture, now all of you are exhausted, yes, tired, but don't worry. Just take a deep breath. Dr. Hakan, a deep breath. And another deep breath. And we will start now. I will try to be so simple and sometimes funny, and we will start now.
Okay. Let's see this.
Bismillah ar-Rahman ar-Rahim. We will discuss with each other today the role of EUS in esophageal cancer with you, Ahmed Morad, Professor of Gastroenterology, Cairo University. Cancer esophagus, as all of us know, that is the esophageal cancer is the sixth leading cause of cancer deaths all over the world. It's about 500,000 deaths per year, and the 5-year survival rate is only 15%. Squamous cell cancer and adenocarcinoma are the two most common types of esophageal cancer, constitute about 95% of all esophageal cancer diagnosis. Squamous cell cancer is more common than adenocarcinoma, except in some Western countries, adenocarcinoma is much more frequently diagnosed. Other than two large types of cancer, 5% occur other than squamous cell and adenocarcinoma, like verrucous cancer, carcinosarcoma of the esophagus, small cell carcinoma, and malignant melanoma. The main difference between squamous cell carcinoma and adenocarcinoma, usually the predisposing factor in squamous cell is smoking, and this occurs in middle and the upper esophagus. For on the other hand, the adenocarcinoma is the sequelae of Barrett esophagus and usually occur in the lower part of the esophagus. Irish, our friend in Irish, said that the only cure for love is marriage. Yes. And I think this woman is cured from love. It appears that's cured completely. In medicine, we said that the only cure for cancer esophagus is complete removal. So just after diagnosis of a cancer esophagus, the treating surgeon asks this question: please put the patient of cancer esophagus in one of 3 categories. Either it endoscopically resectable, or surgically resectable, or unresectable for just palliative treatment. But before we put the patient in one of these 3 categories, we must have an accurate staging. And for accurate staging, we use TNM staging, system staging. The guideline for staging: at the beginning, we do upper endoscopy and biopsy to diagnose that is the cancer and the type of cancer. And after that, we do contrast CT for chest and the abdomen to see if there is any metastasis elsewhere. And after that, if the tumor go beneath the diaphragm, we must add CT pelvis. And if it's okay, no metastasis at all, then it's a time for PET scan to be sure that there is no area of metastasis elsewhere. At the time, the EUS come to be of help now to know what is going on in the local tumor. Some surgeons prefer to do diagnostic laparoscopy if the tumor extends in the gastric beyond or below the gastric cardia. If it is extend below that, need diagnostic laparoscopy. About esophageal histology, as we know, the esophageal layer is mucosa, submucosa, muscularis propria, and adventitia. And the EOS picture is also outer and inner hyperechoic layer of mucosa and adventitia, and it in between muscle always hypoechoic, either muscularis mucosa or muscularis propria, and the in between the submucosa, which is hyperechoic. The eighth edition of American Committee of Cancer Staging provides that for cancer esophagus, if carcinoma in situs high-grade dysplasia, if T1, it's divided into T1A, which involve only the lamina propria and may extend to the muscularis mucosa, T1B, which invade the submucosa but not reach to the muscle, and T2, which invade the muscularis propria, and T3, which involve or affect the adventitia but not beyond the adventitia other organ surrounding the esophagus. And here come T4, which go outside the adventitia, infiltrating outside with involving of the surrounding organ. If the organ is vital, like aorta, vertebral column, trachea, it's T4B. If a removal organ like pleura, pericardium, diaphragm, it is T4A. So this is the staging of T cancer, T1A, T1B, T2, T3, T4A, and TB. Another subdivision of this classification, which is very important, T1A is subdivided into also 3 categories. M1, which is the epithelium, M2, which is the lamina propria, M3, which is the muscularis mucosa. This 3 is not of high clinical value. The most important and the high clinical value is T1B subdivision, which is submucosa infiltration, either superficial submucosa or middle submucosa, or go deep to the depth of submucosa, which must pay attention to clarify which is the patient is in SM1, 2, or 3. It will make a big difference in management after that. As regard in lymph node, it will be as regards the number rather than the site. If 1 or 2, it's N1. If 3 to 6, it's N2. If more than 7, it's N3. M0, M1, according to there is a metastasis for distant organ or distant lymph node or no. So after that, what is the role of EOS in esophageal cancer? At the beginning, we can say that EOS consider is the most accurate modality for loco-regional staging, either for the primary tumor or for the loco-regional lymph nodes. Okay, the endoscope, the conventional one, which is 7.5 to 12 megahertz, provide a balance, a very good balance between resolution and depth. It go outside up to 3 to 5 centimeters, which needed to evaluate the surrounding lymph node and surrounding structure. During making a EOS for a patient with cancer esophagus, you must fulfill a checklist. Checklist contain the TNM staging, the area of primary tumor, the celiac axis, the liver, which is as Dr. Hussein said, we can evaluate the liver for distant metastasis. If we apply all this checklist, we will fulfill the evaluation of the esophageal tumor. As we said here, it is the tumor is limited to the epithelium, so it is T1A. It is not infiltrating beyond the epithelium. Here the submucosa is clear. Here the submucosa is infiltrated, so it is, but muscularis propria is intact, so it is T1B. Here the tumor invade the muscularis propria and reach inside the muscularis propria itself, so it is T2. After that, the tumor here invades the muscularis propria, reaching the adventitia, but not the surrounding structure, so it is T3. If we see here, there is a lymph node maybe flat, but it's okay, a lymph node in single lymph node if there is no other than that, so it is N1. So it is T3 here, N1. Here the tumor invades the adventitia, go outside, so it is T4 as it is affect an organ which is the aorta here, so it is T4B because it invades a vital structure, vital organ which is the aorta here. So management modality of esophageal cancer depends on the site of the disease, extent of the disease, TNM, comorbid condition, and patient preference. Using high frequency EUS mini probe add some advantage that can bypass a stenosis or stenotic lesions, esophagus. It can evaluate a smaller superficial lesion because it have a frequency, high frequency up to 20 to 30 megahertz, but have a drawback that it cannot go beyond the esophagus and can sometimes miss a lymph node or any infiltrating structure, and cannot differentiate sometimes between T3 and T4 as regards the infiltration outside the esophagus. So what the weight of EUS in cancer esophagus staging? As regarded T staging, from the beginning, the accuracy of EUS alone is suboptimal in T1, while with adding endoscopic resection, either endoscopic mucosal resection or endoscopic submucosal dissection, are the best to assess the depth in T1. In T1, the endoscopic resection give a good differentiation from the beginning between T1 and T1A and T1B, and determine the SM staging. Is it SM1, SM2, or SM3? So EMR and ESCD here of vital to evaluate the depth of the infiltration of the submucosa, in the submucosa. Endoscopic resection can be valid, an alternative to surgery, and it's enough for the patient to do endoscopic resection if the submucosal invasion less than 200 micron. If the tumor after removal histopathologically categorized as a differentiated well or moderate grade differentiation with no lymphovascular invasion and new tumor infiltration of deep resected margin, if zero infiltration of the with safety margin of the submucosa. The risk of lymph node metastasis vary greatly between superficial tumors like T1A and T1B SM1, which is only the incidence of lymph node metastasis only 5%. It jumps up to 35% if the tumor infiltrate more deep to the submucosa, as if it's go to the middle of the submucosa or deep to the submucosa. And if it's go inside T3, if it's reach the adventitia, the lymph node metastasis jump up to 80%. In a superficial esophageal adenocarcinoma, I mean that T1A and T1B SM1 only, cancer endoscopic resection of endoscopic resection can be achieved complete remission in up to 95%, and the 5-year survival rate up to 98%, which is a very great result with endoscopic resection only. While in advanced malignancy, when we said advanced malignancy, we mean that T2 or more, it's considered as advanced malignancy and need further management. The most important now risk factor for predicting lymph node metastasis is the depth of infiltration. The survival after management significantly worse once the esophageal cancer infiltrate the submucosa, especially the deep part or the middle part of the submucosa. Just treat it, it means that it's the survival is significantly worse. Okay. So the overall accuracy of T staging in EUS is 85%, and the accuracy of EUS is higher in advanced esophageal cancer. The higher the T staging, the higher the accuracy of EUS. And if the cancer reach up to T3 and if the cancer reaches that the endoscope cannot pass through, it means that usually the T staging reach up to 3. So if you found the esophagus is obstructed by the tumor, there is a higher incidence that this tumor is reaching more than T3. Okay, what about the EUS in lymph node staging? The lymph node drainage of the esophagus is very complex. Sorry, it's not very complex. It's very, 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 very complex. At the start, we can say that except the epithelium and the basement membrane, the lymphatic vessel exists in all layers of the esophagus. This is the clue. If we exclude the epithelium and the basement membrane, all layer after that is heavily fed with lymphatic vessels. The lymphatic spread transversely in the esophagus and from up down bidirectionally, but mostly up and to the right. So the direction of the lymphatic spread in esophagus in all directions. It goes longitudinally and bidirectionally in the area of submucosa and goes circumferentially in the area of muscularis propria. On the other hand, in the lymph vessel in a lamina propria and the muscularis mucosa connect directly to the submucosa and mainly the outer margin of this layer. That's why if the tumor reaches the depth of the submucosa, the incidence of lymph node metastasis is jump highly from 5 up to 35%. And sometimes the lymph vessel go directly to the thoracic duct from the muscularis mucosa, from the most superficial or inner part of the near the epithelium to the thoracic duct directly. And also from the submucosa intermuscularis lymphatic plexus to the thoracic duct in some situation. And again, deep submucosa is so dangerous because it's highly containing lymphatic vessel. Celiac lymph node here in esophageal cancer have a valuable incidence of occurrence as if it's occurred towards the survival, and it's crucial to evaluate if there is celiac lymph node or not. So it's by law you must evaluate the celiac lymph node if it's present or not in a patient with cancer esophagus. The management change marvelously between T1 and T2 if there is a node or not. If there is a node, you must do neoadjuvant therapy, neoadjuvant chemoradiotherapy before the surgery. And if there is no node, you can go directly to surgery. Some prefer to do also neoadjuvant in this situation, but if there is a node, you must do neoadjuvant therapy and you cannot go to the surgery at the beginning. The accuracy in identifying lymph node, if you combine EOS and FNA, it reaches up to 90%, and the sensitivity is 99%, can reach up to that. If we combine all the criteria of malignant lymph node, round, hypoechoic, larger than 1 centimeter, district border, you can say that 90% this is the malignant lymph node if all 4 criteria are combined with each other. In restaging EUS after chemotherapy is poor because there is a distorted architecture of the esophageal wall after chemo and radiotherapy due to inflammation and fibrosis. So after in restaging, the EUS, the sensitivity is okay, is 96%, but the specificity is only 10% because much fibrosis, much inflammation, and it's become not accurate. And for residual leukoregional lymph node after chemoradiotherapy, the sensitivity is 60% and the specificity is 56% in detecting residual lymph node. So at the start and at the end, the lymphatic vessel of the esophagus, you must remember that except the epithelium and the basement membrane, the lymphatic vessel exists in all layers with heavy supply. As regard M staging, in M staging, you must evaluate the left adrenal gland, the free peritoneal fluid if present and sampling, left liver loop, and as Dr. Hussein said, you can evaluate the liver for any distant metastasis if there is a peritoneal fluid or not. And now we can say that EUS have a heavy weight in evaluating the T staging, number one, and to some extent, a good extent, N staging, and to some extent, M staging. And you can evaluate for endoscopic resectability, follow-up, and for evaluating surgical resectability, the possibility of surgical resectability. So we can easily say that EUS is the king in staging of non-obstructing esophageal cancer. But even the king, Dr. Hakan, no, even the king have some limitation. How can we bypass the limitation of the king? The king limitation or the endoscopic EUS limitation here is a structure which is occur in up to 30% of the advanced tumor. We can use dilatation by balloon with low risk of perforation. Dilatation up to 15 millimeter allows successful passage up to 90% of the case if you can dilate up to 15 millimeter. Mini probe can be add a value here, but it have worth that it's limited depth of penetration. It cannot differentiate between T3 and T4 as it cannot infiltrate because high frequency, it's low penetration. It just seeing the layer of the esophagus, no beyond that. In conclusion, we can say that if we have an esophageal cancer, you diagnose it by upper endoscopy and biopsy, do CT and PET scan, evaluate for metastasis. If there is a metastasis, it's just palliative systemic chemotherapy. If no metastasis and you are sure that there is no metastasis by CT and PET scan, you evaluate is it obstructive or non-obstructive. If it's obstructive, you can do blind probe, mini probe to evaluate. If no obstruction, this is the place for EUS. EUS can differentiate if it's T1 and if it's T1 is T1A or T1B with endoscopic resection to evaluate if the depth of infiltration less than 200 in the submucosa. The tumor after removal is differentiated well or moderate differentiation. If no lymphovascular invasion, no tumor infiltration in deep resected margin. If it's all, it's okay. Is only endoscopic resection is okay. If no, if there is a more infiltration, surgery have a role here. If any T with N, you must do new adjuvant therapy at the beginning and re-evaluate by EUS. If T3 or T4, new adjuvant therapy and re-evaluate. If there is infiltration of a vital organ is for palliative treatment. And thank you so much.
I think Professor Patel is the moderator of this session. Do you like to view the questions if there are any questions? I have a question to you, Professor Ahmed Morad. First, thank you for this very clear as usual.
At the beginning, I take the king from Dr. Hakan to the EUS. Okay, Dr. Hussein, sorry. Okay.
As you know, EUS is not so accurate in T staging.
Yes, in superficial T, in T1.
Yes,
in T1,
yes,
T2.
it can.
Yes.
Yes, it can hardly differentiate between T1 and T2.
Yes.
But differentiation of T1 into T1 mucosa, T1M, or T1 submucosa, T1 SM, And even by T1, they have M1 and M2 and M3. It is, I think, the great advantage of endoscopic ultrasound is to scan for the nearby lymph nodes and doing FNA if possible. If there are lymph nodes, this precludes the EMR and ESCD.
Yes, at the beginning.
Are
Yes.
there any techniques, any other techniques or special techniques during EOS examination to increase in its accuracy in local staging?
At the beginning, EOS of good value to evaluate if the patient is suitable for endoscopic resection or not. Can evaluate if it is superficial or infiltrating the muscularis propria. Because sometimes the lifting test cannot be accurate to take a decision if there is a place here for endoscopic resection or not. So EOS of value here because it will give a guide at the beginning to do ER endoscopic resection from the start or not to do it. So it's of value, of high value here.
May I ask a question, Ahmed?
Yes, yeah.
Actually, in most of the time, surgeons are relying on radiologists rather than endosonography. I mean, are you referred patients from surgeons to be staged or do you perform it after you diagnose esophageal cancer? Because in my practice, in most of the time when I discover esophageal cancer, I do a staging by EUS, but very infrequently surgeons are referring patients for staging of the esophageal tumors because they mostly reside on computer tomography. What is the experience of you in your country, and maybe Dr. Patel and Dr. Osman would also comment on this?
Yeah, after diagnosis of esophageal cancer, and especially if you evaluate it as a early malignancy, not so infiltrating, not obstructing the lumen, the first investigation after that, you must do CT, chest, abdomen, or PET scan, or both of them to evaluate if there is extension or not. Because if there is a metastasis, the story will be different. Because it will be no place for surgery from the beginning if there is a distant metastasis. If the tumor, if there is no metastasis by CT, no metastasis by PET scan, here the value of EOS come. The value of EOS come, it's either it's endoscopic resectable, if can be endoscopically resectable only, or you need more than that in the form of surgical removal if there is the infiltration of the deeper layer. EMR sometimes it helps the EOS to diagnose this, and especially if it says just superficial lesion in T1 or T1A or T1B, especially if it's a superficial T1B. And here there is no single investigation can do can give us all the knowledge. It's a combination to exclude metastasis and then to evaluate the role of EOS to categorize the patient either surgical or endoscopically resectable. And I don't know if, yes.
Excuse me, Professor Hakan, you mean comparing EOS by CT regarding T local staging, T staging, or regarding lymph node and distant metastasis?
No, actually, my question was related to the general behavior of the physicians involved in the care of the
here in Egypt,
esophageal cancer. What I mean was that mostly we are performing EOS for staging our patients, but surgeons infrequently referring the patients for staging, even after CT and all the others. They mostly rely on radiologists. Is it the same in your country and in the countries of
No. In my country, most of the surgeons refer for EUS for local staging, not CT. because CT is not as accurate as EUS. EUS is much more accurate than CT in T staging. But we should do CT or MRI for nodal and distant metastasis. But for local T staging, most of the surgeons or nearly all the surgeons refer for endoscopic ultrasound because it is significantly more accurate in T staging, except in anal canal and rectal carcinoma. Here, MRI, high resolution MRI, really is comparable to endoscopic ultrasound in local staging. But in esophageal, gastric, duodenal, or refer for endoscopic ultrasound. And I can tell you that our colleagues which are doing ESCD, they learned in China. They don't do ESCD except after endoscopic ultrasound. Although it is not so accurate, but I think it is the most accurate modality, more accurate than CT and MRI in esophageal, gastric, duodenal, but except, as I told you, in anal canal and carcinoma, and in lower rectal carcinoma, I think MRI may be comparable to EUS for local staging.
CT is far away from EUS in T staging.
Yes.
Yes, it's far away from that, and it gives a knowledge which the other cannot give.
So I really agree with all what you are saying, but there is one thing I want to add regarding to the ESD. When we think now about esophageal cancer, I think about the role of EUS is important to differentiate T2 from T3. And why this is important, T3 will have neoadjuvant before surgery. So that decision is based mainly on EUS in the United States. Tumor board will ask for EUS and will go this way. For T1 lesion, though, EUS is always overstaging. I stopped doing EUS for T1 because I saw that many patients who would benefit from ESD would turn away because the inflammation would show as if it is T2, almost going to the muscle, or it is just submucosal inflammation. So I depend like the same like the Japanese, and initially I was not trained this way in the United States. I was trained that the EUS is the top of the line. But looking at the topography of the lesion in T1, it will tell you if this lesion is deep or not. Beyond T1, if you have suspicious of muscle involvement or beyond the wall, then you can do the ultrasound just to say this patient is going for surgery or going for neoadjuvant. Another thing, lymph nodes, the studies showed that if you do EUS for high-grade dysplasia or early cancer, EUS is not useful unless you find lymph node. And if you find lymph node and it is positive, then now we diagnose T1N1 or T2N1, then it makes different. So it's almost always we do EUS before ESD, but I start to question the value of it because a lot of time I would say, I see the EUS saying it is T1B, but then we resect a lesion and it is T1A. And I'm not sure about if anybody else has the same experience.
Always, Dr. Muhammad, any investigation give one face of the truth, and yes, the other completed. Even lymph nodes, you can see a lymph node, multiple lymph node, and all of them, it's just a dysplastic lesion, not a malignant lymph node. So EUS is not. I prefer to see compatible to add to each other CT and EUS to evaluate the patient. Nothing better.
They are not in competition. They are not in competition.
No, yeah, but I mean, like, but you cannot take
teamwork, not in competition.
Yeah, you cannot take patient for surgery without EUS.
In some countries, there's an investigational technique, endoscopic optical coherence tomography. This endoscopic optical coherence tomography may be better in diagnosing the stage of the tumor. Is that available in the United States?
So the OCT, I had it in 2012, and I bought the machine, $160,000. All right, and then we started using it to look for this buried mucosa under RFA, and it fell out of favor. And recently, the company became bankrupt, and the device We have it sitting in the unit now, and we cannot use it anymore. That's it. It's the story of the OCT in the United States. It was a stage. It's over.
Actually, at the beginning, it was very promising, but I have been disappointed to hear that.
Well, with any imaging, I sat on some committee to come up with consensus criteria for interpreting the images, and we had about a list of 15. Thick black lines, thin white lines, and these very subjective, criteria. And it was clear that it was not going to be reliable for consistent use. So I think what we're all excited for is automated imaging. And as we've heard at recent conferences, this is a lot of interest in using our AI algorithm, to process, what we're seeing instead of relying on our old man eyes that we're used to.
Yeah, because EUS is very subjective too. Like I would be doing the EUS and somebody say it is T2, but then you just move the scope a little bit and you say, well, actually it is going through the wall. It is T3. And a lot of time we wonder, should we send the patient for neoadjuvant or for surgery right away? I wish we will have better, I think with artificial intelligence, we may have a better criteria. I hope so.
And here also, with most GI cancers, at least in the United States, it's really turned into, can you endoscopically remove it? And if not, they almost all are going to get systemic therapy before surgery. And this has become true for many of the tumors. And so I think the role for us will be more along the lines of, are we going to endoscopically remove it? Yes or no, and that's it. And I know I don't perform ESD, Dr. Hoffman does. I believe some of the surface characteristics of the tumor are almost as predictive for T1, T2 as EUS. Can you comment on that?
Yes, and the Japanese, I was surprised when I went to Japan that they do not utilize EUS as often as we do in the United States, and also in Egypt and Europe, because we do almost EUS for newly diagnosed like esophageal cancer. We just do it right away. And when I went there, I found that they spend a good amount of time just looking at the lesion and doing a chromoendoscopy and predicting the pathology. They would only do EUS if they think it is beyond T1B. So they wouldn't do EUS for T1. And if they are going to do an EUS, they will use the mini probe. They wouldn't use the radial scope.
I believe there's a question for the beginners out there. Is there a difference between the linear and the radial scope for staging in the esophagus?
Radial is more easy for staging usually, but usually in Egypt there is no radial at all, because if we have a budget to buy an endoscope, we buy a linear one, and we have budget to we have two linear till 10 till 10 EOS we must. So we don't have a radial one, but it's more easy, but it's not practical in FNA, which is the must, because if we have a suspicion, even if EUS of cancer esophagus, FNA have a great role to take.
Can I add something?
May I raise another issue? Is that in some patients, there are symptoms of eating dysphagia, but endoscopy did not reveal malignancy. Even biopsies are negative, but in some of these patients with endoscopic ultrasonography, we diagnose laterally spreading esophageal carcinoma. So I think apart from staging of the endoscopically apparent esophageal malignancy, if there are symptoms suggesting of malignancy but endoscopic biopsies are negative, I think one should resort to endoscopic ultrasonography. And actually we published data about the esophageal subepithelial lesions in endoscopic ultrasound. And in this series, there were 4 patients initially referred to us for the evaluation of endoscopic subepithelial lesion, but it appeared that these were laterally spreading tumor.
Yes.
Yes, can I add something to this question? I worked for about 10 years with radial echo endoscope, and then after that, since 2008, I worked for 12 hours with the linear. I think no difference at all in staging of esophageal cancer between linear and radial, but in case of linear echo endoscope, we should turn the echo endoscope clockwise and anti-clockwise to visualize the whole circumference of the tumor, because if you centralize the linear echo endoscope at a single position, then you are scanning the middle third or part of the tumor, but you should go here and go there. It's very easy maneuver, not dangerous maneuver. So I think no difference at all if you are careful about rotating the echo endoscope to visualize the whole circumference of the area of the tumor.
Yeah, and especially a lot of time the air can interfere, and linear is better than radial. Like and now we are rarely using radial anymore, even if we have it, because we got so good in using the linear, and we prefer the linear over radial.
You can center as the radial to us.
If you're not using it,
Professor Patel, I think no questions, no other questions in the Q&A. Very little questions because the lecture is very clear. So the most clear lecture today is the lecture of Professor Ahmed Morad, because there were the least number of questions. I think we now came to the end.